Hello and welcome to Oral Health America, Smiles Across America's webinar series, Share and Learn. My name is Terry Gray-Nanabu, the Smiles Across America Program Coordinator and Fellow. Please connect with OHA through our Facebook page and Twitter accounts. Before we get started, I'd like to do a little housekeeping. We ask that you please mute your phones. Questions are welcome. Please type your questions to the control panel on the upper right hand of your screen. We will allow 10 to 15 minutes after for questions. Because there are two presenters today, please indicate which speaker your question is for in the drop-down box. This webinar is being recorded and can be viewed on our site, oralhealthamerica.org. Your feedback is important to us. Please take our brief evaluation after the session. A link will be emailed to you. Oral Health America's mission is to change lives by connecting communities with resources to increase access to care, education, and advocacy for all Americans, especially those most vulnerable. We do that by our programs and campaigns that influence healthy literacy, improve access to services, and advocate for systemic changes that will impact the oral and overall health of all Americans. Let me tell you a little bit about our program. This year marks the 10-year anniversary of Smiles Across America, which aims to bring oral health care and education to children across the country. The Wisdom Tooth Project focuses on older adults and the current oral health crisis facing this rapidly growing segment of the population. For more information, please visit toothwisdom.org. Campaign for Oral Health Equity is our advocacy campaign. Campaigns under this are our Fall for Smiles and the National Spit Tobacco Education Program. Let me share a little bit more about OHA's Smiles Across America program. We provide grant funding annually to school-based or school-linked programs in 43 states. Currently, we have 193 partners and serve 439,351 children. Through our Product Donation project, we are able to distribute over 500,000 units, of leading dental products such as sealants and fluoride varnish to school-based or school-linked programs. Through our Seal 2 Million campaign, we are committed to seal 2 million teeth by the year 2015. We are already halfway to our goal. SAA supports partner organizations by providing technical assistance such as informational webinars like these, grant writing assistance, and communication tools. Lastly, supportive research is another key initiative where we focus on current trends and practices, such as parental consent. I would now like to introduce our first presenter today, Krista Postai. Krista Postai, an original founder and former board member of the Community Health Center of Southeast Kansas, the only federally qualified health center serving the poorest region of Kansas, now serves as its President and Chief Executive Officer. Prior to joining CHC SEK in 2004, she was Vice President of Planning and Development at Mount Carmel Regional Medical Center. During her 23 years at the Medical Center, she was instrumental in development of several mission-directed services, including non-emergency transportation, congressional health ministry, and volunteer dental clinic. Currently, Krista is overseeing a $5.5 million expansion of its clinic in Pittsburgh, expansion of a dental clinic in Lola, and the opening of a new site in Independence in collaboration with Ford County Mental Health Center. She is a founding board member of the Eastern Kansas Health Network, committed to improving the region's health outcomes indicators, increasing access to health care services for all, and developing a regional IT infrastructure. Welcome, Krista.
Thank you. After that introduction, I'm tired, so I appreciate the kind words. So greetings, Kansas. It's a privilege for me to be speaking to you today. It's my very first webinar. Hopefully it won't be my last. And to share with you what it looks like in our region in dental care. I don't come with the traditional qualifications. My degree is actually in journalism, photojournalism. But what I do have is a passion for helping people and the ability to find the right people to do the job, and people who want to make a difference, like you folks out there. So on to today's objectives are not going to be to tell you how great we are in Southeast Kansas, although I may do a little of that, or to pretend that we have all the answers, because we don't. But I want to leave you with the idea that if we can make it work in the poorest region of the state with a critical shortage of dentists, no money, and run by a photojournalist, it can be done anywhere. A little background on where I'm coming from, literally. We are based in Southeast Kansas, and if I could have the next slide, please. This is the Kansas County Health rankings that are available to the University of Wisconsin. We're that mustard or that yellow in the right-hand corner. We're the oldest, the poorest, and the sickest in the region, and have the worst outcomes and health indicators, and we're working to try to turn the ship around. So that's what I do how I spend most of my day. So hence the Eastern Kansas Health Network. Our children, and that's the next slide, start out at a terrible disadvantage. At least half of our babies are covered by Medicaid. In one county, it's 2 out of 3. In some school districts, we see active decay in more than 50% of the kids. We have the highest rate of out-of-home placement in the state, probably as a result of the high rate of child abuse and neglect. The federal government has declared us a high drug usage area, and on and on. So every time we write a grant application and I start citing the data, my CFO always swears he's going to move. I think the number of people take their numbers a little too, believe them, it's a little too much. It is a challenge, though, and so our goal is to move the needle. So to our beginnings, which is the next slide, this is where our innovation began. We were originally a department of a 100-year-old Catholic hospital that had been innovative from the very beginning. They started the first prepaid insurance plan in Kansas in the early 1900s. And the sisters would go around to the mines and collect 25 cents from each miner. And our area did grow up as coal mining, lead, zinc. So we're heavily into mining and not farming, as most people think of in Kansas. So the sisters would go from mine to mine on payday and collect the 25 cents. They said they did that before the saloon got it. And that's how they covered the cost of family care, health care. So it's helpful to grow out of an organization that's willing to take risks and be innovative. Our center opened in 1997 as part of a project called the Family Resource Center. That's that 90-year-old school building you see on the right of your screen. And it was the idea of getting children ready to learn, 0 to 5. And out of that came the idea of centralizing all services in one location to make it easy for parents. So our medical services were in a double-wide trailer out back, which is the bottom picture. And our dental clinic was in a 12-by-12 closet at an outreach mission of the Methodist Church that was just down the street. Today, and this is our next slide, we are the largest federally qualified health center among the 17 in Kansas, serving 35,000 patients through 130,000 encounters at 10 sites, and 40% of those are dental. Almost half of our patients are children from our very beginning, is focusing on kids. Our annual budget has gone from $1 million to $17 million, with only about 25% of our funding coming from grants. The rest we do earn ourselves, and about 45% of our patients are self-pay. So things like free dental supplies and free sealant material and toothbrushes mean a lot to us. So special thanks to Oral Health America for every tooth they've helped us seal from actually since 2004, they've been with us, or we've been with them. So back to the next slide. So back to early days of community health when I just started, and I recognized the era of look ma, no cavities that I grew up in the 1950s was a thing of the past, or maybe never had really been. But I did most certainly remember that dentists came to our schools and kids lined up to get their teeth checked, followed by a Tootsie Pop, which made it a special day. And I wondered what had become of that and why it ever ended. About that time, the United Methodist Health Ministry Fund offered its first oral health grant to seal teeth for children. And we were attracted to the part of the grant that said you could use whatever was left over to start a dental clinic. We sealed 400 kids' teeth. We had $10,000 left over, and that's how we built that little dental clinic, and that's the whole dental clinic you're looking at right there, with hand-me-down equipment that we pieced together from 3 different retiring dentists. It all worked, but never on the same day. So about a year later, Kansas Mission of Mercy came to town, KMOM, and a lot of states have these where volunteer dental professionals come together over a weekend and provide services to long lines of people. I'm sure a lot of you have worked at them. We served almost 2,000 and gave about $1 million in care, and we learned the power of participation. We recruited hundreds of volunteers, from oral surgeons to Rotarians, and no one ended that weekend without an awareness of how dire the situation was. And any of you, if you have to do this kind of fundraising, again, to support this kind of thing, we did something cool. We addressed postcards to all the donors and had people, as they left, write a thank you note on them. And we mailed them back to the donors after the event. And one of those guys, he was a banker, walked into my office. He had the whole stack. He had a whole pile of thank yous. And he sat down and read every single one to me. He cried while he was reading them. And then he wrote me a personal check for $10,000 for our little dental clinic, which is something I could have never done on my own. So the power of the thank you, we never overlooked. The problem, though, was within a month after KMOM, we had a waiting list at our little clinic for 750 people, which was unimaginable. So I called a local dentist, and he's pictured in the next slide, Dr. Dan Minnis. He co-chaired the local Mission of Mercy and told him our problem. Then I made the mistake of leaving town to go to a conference on how to run a community health center because I really didn't have much of a clue at that point. And I got this call from him, a voice message, that he just bought a vacant auto parts store, taken a bank loan out for $500,000 to renovate it into a dental clinic for community health. But I wasn't to worry. And at this point, I'm thinking all dentists are crazy, and I don't have the money to pay the water bill on a double-wide trailer, so I wasn't sure how I was going to pull this one off. But the takeaway message from this is that every dental program needs a champion, preferably rich ones who can get bank loans with a phone call, but just someone who's really passionate and dedicated to the concept of helping people. So long story short, he carried the loan for us until some local and state donors, and I can show you what the dental clinic looks like on the next slide. And we opened it in August 2005. We had a big open house, invited state officials, all the donors who helped make it possible, and my board chair comes to me and says, well, what am I supposed to say to all these people? Because we have a one-day-a-week dentist and a one-day-a-week hygienist, and everybody's looking at us like we're going to save the world. So I said, we came up with this idea of announcing that we would screen 5,000 school children for dental decay in 5 months, like they used to do in schools, except no Tootsie Pops. We do toothbrushes instead, and apply as much fluoride varnish and sealants as we could. She announced it. All the guests smiled and clapped, and the one hygienist I had in the back of the room let out this audible gasp, close to a scream. And the other lesson I learned that day was to make sure you communicate with staff before you announce things like that. And the dentist who bought us all this or helped get us all that leaned over to me and said, you know, we're never going to be able to recruit a dentist, which is not the time to be telling me this, but fortunately he was wrong. We went on to see more than 5,500 children in 5 months in schools and realized we were on to something, and then recruited 2 full-time dentists within 6 months. So people started coming to us and asking us about our not-so-little clinic now, and here came the idea of the dental hub and spoke, and that's the next slide, conceived by Jason Wesco, who was with our state association at the time. And the concept was to take clinics like ours, existing clinics, and develop core dental programs defined as a hub and spokes coming out from them, fixed satellite clinics or mobile services to schools or nursing homes. It would focus on oral health and create the opportunity to integrate medical and dental professionals, the dogs and cats I referred to in my objectives, which do exist in two very different worlds, by putting them in the same space. On the next slide, it shows you how that really looks. It was a very simple concept that included multiple dentists, at least one hygienist working in the hub, and spokes with hygienists with extended care permits, which in Kansas allows them to work independently of a dentist in low-income schools and Head Starts and nursing homes. Targeted populations were the underserved, and which is quite a few people, since most dentists in Kansas don't take a lot of Medicaid. There are some exceptions to that, and they've been great partners in our efforts. The staffing model, which is the next slide, was intended to create a stable clinic to accommodate the new generation of dentists. The single dentist model, prevalent in Kansas and most other states, was fine unless someone got sick or wanted to go on vacation, and with more women entering the field, allowed them to start families without going bankrupt. It also maximized what hygienists could do, which is not a concept widely embraced in rural areas here. And it allowed us to go where the underserved patients were, eliminating the barriers of lack of transportation. And this gives you the staffing. So on the model specs, which is the next slide, recommended the kind of equipment we needed and the kind of staffing, the services we would do, and the productivity, because most of the people involved in this project were people like me that didn't speak dental and had no clue what this should look like or how it should operate. And the productivity standards were the ones recommended by the feds through HRSA, and this was the model. So on the next page, you're going to see what we looked like before the dental hub. He put the concept down in 3 pages, highlighted the need, and then he suggested the state association get with all of the private foundations in the state of Kansas that fund health and asked them to jointly fund this project. It actually turned out to be an easy sell. They had never come together like this before, but they understood the oral health needs because independently they'd all participated in K-MOMs. And so we got 7 funders at the table who were able to sit down, merge all their requirements, all their expectations, all their grant cycles into one. They went all in. And the next slide, this is the after, 5 years later. And in the middle of all this, Jason Westwood comes to work for community health. He brings his idea of the dental hubs to us, and we pilot it. And for those concerned about the eastern half of the state, that where Overland Park, Johnson County is, Jason has since left here, and he's up there and opened a dental clinic, another federally qualified health center, and 60% of his patients are dental. So he's filling in that block up there, and others have gone to western Kansas. We still have dental deserts, but for the most part, this program was extremely successful, and Colorado has approached us about trying to replicate that, and they're working on it now. The trick, though, is to have initial funding. So the impact on us specifically, the funders over a 3-year period invested $6.1 million in oral health, and $1 million of that came to us. They allowed us the flexibility of actually asking for whatever we needed. It could be renovation, it could be equipment, it could be providers, it could be dental navigators. So this has worked incredibly well. So we now have 4 full-time sites, and when we lost a dentist at one, we were able to continue to staff it, actually improved our numbers by bringing in dentists from other places. It also allowed us to get the best equipment in the world, which helps us recruit, because the new young dentists have never worked on paper charts or traditional x-rays, and they really need this to do a job well. It's what they know, and it makes no sense to ask them to go backwards, and we don't. So that's what we look like now. But let me go back, and that's the next slide, is a concept of lining up in school and that 5,000 kids in 5 months. As an FQHC, we're incentivized to accept Medicaid. In our region, very few dentists do accept Medicaid. And with the changes in our program and with Medicaid in the state of Kansas over the last 2 years, more are dropping out. So using kindergarten math, we figured out for every 3 Medicaid children we provided service to, we could afford to provide care to 1 uninsured adult. But rather than try to sort that out in the scheduling department, we just got creative. We went to school enrollments and set up our table next to the lunch ladies, and lured parents over to the table to sign their kids up for screenings. We convinced the state of Kansas to allow us to do presumptive eligibility, which is sign up kids for Medicaid on the spot and get paid for it. We did a multiple kind of activities, again, to target children so that we could take care of their parents. On the next slide, shows you what we're doing today. Today, every year, we go into 150 school buildings, every Head Start in southeast Kansas, and every women and infants clinic, WIC, throughout the region. And altogether, we screen about 22,000 kids a year for dental decay. We got a lot done. We know we can still do better. We work closely with KDHE's Bureau of Oral Health, which started a statewide screening program and attracted some federal funding, which we benefited from. And we've seen the mouths of our children dramatically improve statewide and found a way to keep our clinic doors open. I think there's a couple more pictures there that show us doing outreach. But and before I share the data, though, and I want to go to the next slide that's got a link on it, I do want to share another secret to our success. And we need to keep going. Oh, there's got to be another slide there somewhere, but we'll get to it. We had many other programs come to us and say they couldn't get into schools. They were frustrated with working with education. Even my staff would come back complaining that the setup was all wrong or the consents weren't right, and one even got into a screaming match with the principal, and getting back to that school took me 2 years and a lot of talking. We stepped back and walked in their shoes instead of ours and realized that we weren't making it any easier. So we compiled a school health dental manual that walks schools step by step through the process, whether it's a school screening or providing mobile dental work, down to how many chairs and the size of the table. All the forms, instructions for each type of clinic, everything's in a notebook that we gave them, which we also put on our website. It also includes parent education with pictures of who's coming to the school and their credentials so they can see these are well-trained dentists and hygienists. And descriptions of what we do. As a parent, fluoride varnish sounded to me like you're going to cover my kid's teeth with furniture polish. And I know that's not true, but we tend to forget that language, our language, isn't everyone's language. So we put it in layman's terms and explain why it's a good thing. And so here's the link. If you find anything on there helpful, help yourself to it. Because it changes every day. We update it on our website. But this has everything you need. So here's what we accomplished. Specific to our region, and this will be the next slide, once the worst in the state, we've seen our percentage of third graders with untreated dental decay go from 28% in 2004, when we started this project, to 12% in 2012. But there's still lots of work to be done. We're not seeing much progress beyond the 12%. We're going back to the kids year after year, and a large percentage, most of the kids, have the same cavities they had when we were there last time. Even though we refer them to their own dentist, they aren't getting there. So this year we're opening our first full-time dental clinic in a school, and we're doing as much mobile dentistry as we can in the highest need areas. We have pushback, and we expect pushback from local dentists, but the data is compelling. We do invite them to join us so that they'll be part of the process, although most spend their time writing letters to the congressman, which then I've been addressing. But it all goes with the territory, and again, the data is so well established, it's hard to argue with it. And then quickly, I want to go through some innovation on how this translated into integration. Before there was even research on the impact of oral health on overall health, we began putting dentists in our dental clinics, making sure our diabetics and pregnant women had priority access. We've created automatic reminders in our electronic medical record that get them scheduled for their dental appointments when they're in to have their diabetes checked. And we're adding case managers to make sure they're following up. We do blood pressures on all dental patients and refer them immediately over to the doctor if it's high. We check blood sugar levels. We've taught our dental assistants to do INR testing in our dental clinics for those patients on medicines that impact the ability of the blood to clot, so we don't have to send them to a doctor and then have them come back again. Until state funding was cut, which was just a couple years ago, and they're telling us it's going to be restored, hopefully. We did rapid HIV/AIDS testing on all adult patients in our dental clinics unless they opted out. And ironically, the only 2 cases of HIV/AIDS that we've identified originally came from our dental clinic by dentists who looked in the mouth and saw something suspicious. We've also done in-services for our doctors, our medical staff, to educate them on dental caries and pain and how to recognize it. And it's becoming quite common for our dentists to go over to the medical side, take a look at a patient, and we're using panoramic x-ray on our medical patients. And if you don't think this makes my billers crazy, it does, but it's good care, and we're actually blending the 2 fields. We're truly integrating them. So back to the poorest region having some of the greatest outcomes. And this is the next slide. In one of our counties, the poorest county, in the poorest school in the state, and there hasn't been a dentist in this town for a decade, there is a district that's way ahead of everybody else because they've got a superintendent and a school nurse who get it. We've done it all there. It was our first school where we did everything: screenings, fluoride sealants, and restorative care. There are 770 children in this district, and we went in and completed 300 treatment plans on those kids who did it and who needed it. Administration says the janitors are complaining to him about the white foam on the sinks because the kids all brush their teeth after lunch now. And I show you the football team, which is this last picture that should be coming up, because for the first time in the school's history, they made it to state playoffs. And this was after we provided dental pain or care to one of their star players who'd been sidelined because of dental pain and hadn't been able to play for the last 2 games. So my statement is that it can be done here, it can be done anywhere. It just takes people who care. And then finally, I want to take a few minutes to talk about inspiration and my objective on how to reach out and get programmatic support, or at least how we did it. So while the numbers and data, like I showed you, are great, there's something far more powerful, and that's the stories behind them. And let me share one of ours with you. 5 years ago, a local rich lady found a women's giving circle to encourage local women to be generous, and they requested grant applications for health programs benefiting women. We asked for money for a program we call Bridge to Work. We identified women who'd been abused as children or as adults or children, or their teeth neglected, and we fixed them. We still fix them. And you know these women, they work back in the kitchen, or they can't get jobs because of their appearance, and we do this work at no cost, thousands of dollars worth. They have to be drug-free, keep their appointments, make sure their children get their dental care. They go through a rigorous interview process, and their stories are heartbreaking. One woman was shot in the face by a drunken boyfriend. Another, whose 6th grader, asked her never to come to school with him because of her appearance. But the difference is life-changing, and when it's done, everyone cries, including our dentists who say this is why they went to school and this is why they became dentists. And most of these women get jobs, but every single one of them have gotten their self-esteem back, which is an incredible gift we can give and you can give. And last year, based on this story, United Healthcare came in, a major insurance company, and they now fund it after my original grant ran out. But I will tell you, I've told that story 20 times before I had anybody step up with funds. So you have to tell your message over and over again. But there are a lot of people out there who care. So on to the next slide. Behind all the numbers are the faces, especially the children. And you all have the power to put smiles on them. So don't forget to tell their stories. And they're your stories. And not only will it attract financial support, but it will remind everyone who does this work every day, it will remind you what an impact you're having. So I want to thank you for your time and attention. And my last slide, I want to thank Oral Health America for making our work possible. And by the way, every child in this picture had fluoride varnish 2 weeks before we shot this picture with the check. So those are real smiles. So thank you very much, and I will turn it back to you.
Thank you very much, Krista. That was great. Again, if you have a question for Krista, please type your questions in the upper panel under the Questions tab and indicate that the question is for Krista. I now would like to introduce our next speaker today, Lindsay Ray-Ehlers. Lindsay Ray-Ehlers is the Executive Director and CEO for the Ronald McDonald House Charities in Omaha. She is responsible for providing leadership executing the strategic vision, fiscal responsibilities, board management, and for all major giving for the organization. She is originally from California and has been living in Omaha for the past 4 years. Lindsay Ray brings with her a diverse professional background, inclusive of academic administration, nonprofit management, and environmental compliance. She earned her undergraduate degree on the President's List for English Literature at California State University, Long Beach, and her Master's of Public Policy from California Polytechnic State University in San Luis Obispo. Welcome, Lindsay.
Thank you. Can you hear me okay?
Yes, I can hear you perfect.
Okay. Thank you so much for this opportunity. You're making huge strides. Oral Health America is a huge partner with the Ronald McDonald House, and I'm honored to be a part of it, and I appreciate the opportunity to be here to talk about what we're doing. So when I was approached to do this webinar, I was positive that there was no one who might possibly be going through some of the same challenges that we are. So hopefully this is beneficial to everyone in some way in terms of poverty and working in areas of poverty, working in areas that are challenging. And it was disclosed after we had talked for a while that there might be some people who could be in alignment with where we find challenges too. So today I'm going to talk about our CareMobile and what that is and the people who benefit from our services and the people who don't, more importantly. Just a few details about the CareMobile for those who aren't familiar with what that is. It's a 24-foot mobile dental clinic, and we serve local underserved children who attend Title I public schools. So the majority of the kids who this serves, 87% or so of the school is on free and reduced lunch. We provide cleanings, sealants, x-rays, fillings, minor oral surgery, and oral education. There's no charge for our services, and it's run with one full-time dentist and a full-time dental hygienist on board. Next slide. Currently, we are serving about between 850 and 950 students through about 1,500 different visits. The total value of this work comes out to be about $407,000, and these numbers are incredible, and we are addressing a huge need. However, there's a massive population of students who remain with needs unmet as a result of tensions that exist between two bordering areas of town. So in order to understand how we came to this and why this is happening, I'm just going to share a brief history about what is going on in Omaha and how we got to this place. Next slide. So Omaha is exceptionally segregated. It's one of the most segregated cities still in the United States. The map that you're looking at now has one dot for every single person who lives in this town. The blue dots represent the white people. The green dots represent North Omaha, which is where the majority of all African Americans live. The orange dots represent South Omaha. So the green area and the orange area is what we're going to focus on primarily today. Our partnership is with the federally qualified health center that exists in South Omaha, where you see the orange dots. So moving forward, the history on why things are the way that they are. In the early 1900s, and I won't get too deep into this, but there were race riots that existed here. There was extreme racism that was vibrant in this area. And one of the things that were happening were landlords putting on race-restrictive covenants. In other words, the properties for sale and rent were restricted on the basis of race. And the purpose behind that was that they wanted to keep North Omaha black and they wanted to keep everywhere else white. And so literally, these landlords were not allowing anyone who wasn't white to live anywhere else other than North Omaha. So that's the history of North Omaha. The history of South Omaha. In 1955 or so, the stock markets were huge. The stock markets and meatpacking industry became so big that it turned into sort of a California gold rush type of environment in terms of people rushing to come and get jobs. Over half of Omaha's working population was employed in some facet by the stock market. So It was huge in terms of abundant economy and people having jobs and people thriving, and that lasted for a little over 10 years, and by 1967, the stockyards had completely plummeted for a number of different reasons. Everyone who worked for the commission firms, the railroad that was just for livestock, the 19 different meatpacking companies, everyone had lost their job. Next slide. So what happened from there is that the historically ethnically diverse areas of North and South Omaha became concentrated, even more so by economics, race, and class. And because those workers suffered dramatic job losses during the industrial restructuring, poverty became exceptionally widespread. Right now, next slide, Omaha contains almost 20% of every, well, let's just say 20 out of 100 children are below the poverty level, and that's above where it is in the state. We have an exceptionally high percentage of uninsured patients overall, and the two areas with the highest evidence of poverty also represent the two areas that oppose each other with the strongest racial tension. Next slide. So the people, there's a relationship between health outcomes and poverty. That relationship is linear. And for every incremental increase in income, there is an improvement in outcome for health care. So if you look at this graph, the people who need the health care and the people who have the difficulties in finding it the most are those who are low income, African American, and Hispanic. And that's who we're talking about today in terms of where the biggest problems are and who we're trying to serve with the Ronald McDonald Health Care Mobile. Next slide. So in 2006, there was a needs assessment done in Douglas County. That's the county in which Omaha resides inside of. And it showed that the two greatest areas of need were in access to care and oral health care needs. So there's proven evidence-based interventions regarding fluoridation and school-based dental sealant programs as the best way to intervene on future tooth decay. So we decided to create a partnership with One World Health Community Health Center, which is the South Omaha Community Health Center. Next slide. This agency is a federally qualified health center, and what that means is that they receive a number of different benefits. Specifically, they have enhanced reimbursement from Medicare and Medicaid, and they have to serve an underserved population, sliding fee scale, et cetera, which means this is exactly who we should be partnering with because they have, a little bit more money from federal grants, maybe not as much in terms of hospitals as far as funding is concerned, but from federal assistance, they get quite a bit to help in the areas that we are looking for specifically. Next slide. And the specific benefits that come from that is something called the Section 330 of the Public Health Service Act. And what that means is basically more dollars that come in to provide new access point grants, and that provides funding to support new service delivery sites and provide comprehensive primary health care and access to oral health care and health services. So what that means is they get funding for new access points. They also get funding for expanded medical capacity grants, which means that if you want to expand access to the primary health services in their current service areas by adding new medical providers or medical services, or they want to expand their hours, there's funding specifically for that. And then the third area that they specifically receive extra funding for is for service expansion grants to provide new or expand existing mental health, oral health, pharmacy services, et cetera. So the Care Mobile as a mobile dental clinic can benefit from any one of these different areas specifically that we wouldn't be able to benefit from if we were partnered with a hospital. So these are all really great things. Next slide. The one area that is interesting is that there supposedly are boundaries connected to where these federally qualified health centers can function, or at least that was the story that we were told in terms of how the Care Mobile was functioning. And a service site, so where these healthcare centers would reside is any place where a health center either directly or through a contract arrangement provides required primary health services or additional services like a care mobile to a defined service area or population. So that really includes almost everywhere they can reach. And in reference to boundaries, healthcare centers should address the acute care needs of all who present for service, regardless of their residence. That's what they're supposed to be doing. Next slide. The specific population that should be served is obviously the underserved, but who they're targeting specifically is non-English speaking groups, folks who are homeless, newly arrived immigrants and refugees, and that group is specifically who resides in the areas that we're targeting in North Omaha and in South Omaha. To maximize their limited resources, and everybody has limited resources who's a qualified health center for the most part, their job is to increase access to care for patients, which is one of the biggest needs in most communities. And they're expected to collaborate in service areas where there is overlap of these same target groups of non-English speaking, homeless, and newly arrived immigrants and refugees. The goal of collaboration is to utilize the strengths of all involved organizations to best meet the overall healthcare needs of the area's underserved population, right? So in other words, everyone should be working together regardless of how close or far away you are. So next slide. What's happening in our area is we've got the one federally qualified health center who we're working with and another federally qualified health center in North Omaha who originally, when the partnership began, they said that they would work together and they would service through this mobile dental clinic all of the patients in need, the pediatric patients in need. What began to happen, of course, was a reemergence of racial tensions that had existed before. All of a sudden, the care mobile would be parked out of a school that was in one area of town, and that area of town didn't know about it, and so then it became a race issue again. And these types of scenarios started to spiral out of control to the degree where one health center said, "Don't you dare bring that care mobile into our neighborhood again." Next slide. Meanwhile, the Ronald McDonald House is stuck in the middle, and the Ronald McDonald House thrives on inclusivity. We don't care where you're from. We don't care if you're from Florida or Afghanistan. All we do is help people without borders. Our goal is to provide health, hope, and healing to whomever needs it. So this type of argument doesn't fit with our moral and ethical code. We thrive as a business by including everyone. Next slide. So what we needed to do is to bring these two industries back together. And again, we got really lucky because there was a leadership change at one of the organizations, which helped out a little bit. And so sometimes you might be able to walk out in that scenario if you've got a situation where people aren't working together and you're trapped in the middle. Through that leadership change, there was one opening for one conversation to be had between the two healthcare organizations. And through that, they both agreed, and there was a little bit of tension there at first, given that there hasn't been a relationship there for a really long time. Everybody agreed to give a little bit. So what that actually means is the South Omaha facility agreed to allow one of the dental hygienists from the North Omaha facility to work on the care mobile. The service agreement with Ronald McDonald House remains with the same hospital. We just consider that as a contract for services. But because there's such an issue with the logos even that are on the care mobile and what that represents and what area of town that represents, there's a big statement there. So we agreed, even though we don't have any donor logos or any other logos other than the service provider that we contract with, the Ronald McDonald House agreed to include their logo on our care mobile so that the tension is eased when going into these different neighborhoods. And as a result, everyone in North and South Omaha can now be served, and North Omaha is giving quite a bit by servicing those kiddos that they wouldn't look at before, and South Omaha is pushing forward in a way that complements what North Omaha is looking for. So obviously, the Ronald McDonald House and these two other agencies are a very small piece in looking at something much bigger, but we together like to think that maybe this is the first way that we can build a bridge to eliminate even just a small bit of racial tension, maybe even segregation at some point. I know we're a long ways away from that, but our hope is that this is the first opportunity to open the eyes of everyone who can receive benefits from this and see that it is okay and that it's not determined by race, that all of us have the opportunity for hope and healing. Next slide. Are there any questions?
Thank you very much, Lindsay, for a fantastic presentation. Yes, so if anybody in the audience can type in their questions now. The first question for you, Lindsay, is can you tell us about how many children you serve and how many schools you serve?
So we serve about 9 different school districts, and between 850 students and 950 students, depending on the year, depending on weather, that kind of thing.
Great. And how many dentists are staffed on the CareMobile?
1 full-time dentist and a dental hygienist, and that they're employed specifically by the federally qualified health center to work only on the CareMobile, and they're full-time.
Great. Thank you. And this question is for Krista. Can you elaborate on your booklet that has all the forms and consent forms? And can you tell us about, does that increase the return of consent forms? Do you face any challenges with returning of consent forms or getting parents to sign?
We did actually have a tremendous challenge on the consent forms. So part of this was we would go in, the nurses, we don't have a lot of nurses in some of the schools, so these are often the principal's assistant, and forms didn't get out on a timely basis. So consequently, in Kansas, screening is opt-out, so we don't actually need the forms returned to screen. We do need the forms returned to do fluoride varnish and sealants. So once we got this notebook in the hands of the nurses, and we had someone go around and visit with each school independently, walk through the forms, it's got everything. It's got the consent forms. Again, it's got step-by-step. It's got, if we're only doing screening, what we need. If we're doing fluoride, it tells them when to send the forms out. It suggests that they do the forms a second round. If we don't have enough, come back. And so we actually went from about 16 schools to the 150 you saw on the screen. So having those forms in their hands made a huge difference, and also being able to electronically download them and print them off also made a difference. So yes, we had challenges with getting forms returned. We typically have, for fluoride varnish and sealants, about 65% of the forms come back. And we have gotten to the point where in some schools, the nurse will actually get on the phone and follow up. One school, we had a 99% return rate because the nurse cared, but part of that was also establishing a relationship with her, and we did more education with the nursing staff as well as some of the school boards. We made presentations on the impact of oral health. It's the #1 reason for school absenteeism. But this one superintendent that we started out with at this one school district told 2 superintendents who told 4. So this was actually about a 6-year journey from 2 schools to the 150. But having the forms, a notebook printed that is permanent and also available electronically made a big difference because half the time the nurses were too busy to mess with it, and we understood that. They were also too busy to do follow-up. So we'd go back, and there was a stack of forms that they hadn't followed up with the kids. So we started hiring dental navigators who go into the schools now and work with the nurse and follow up with the calls to the parents. So it has required a lot of extra staffing. Dental hubs helped finance that. And the Medicaid reimbursement, that incentive does cover our cost. So if you have money to start it up, you can find money on the other side to keep covering the cost.
Great. And Krista, what's another one of your biggest challenges that you face?
Oh, that's a great question. I will tell you that funding, after the big push for oral health funding, other programs have taken the place. So we are constantly challenged to find money to cover the adults. And that's why we did that other program, is because we can't cover, these kids all come with parents, and the parents' attitude toward oral health really matters. So our number one challenge is finding coverage for adults. Kansas has opted not to expand Medicaid, and so we have a lot of adults, and most of our adults we see are for extractions, not for restorative work. So much of our energy does focus on the children to make sure they have healthy mouths going into adulthood.
Perfect. And that was our last question. Thank you once again, Krista and Lindsay, for joining us today for the Share and Learn. And please check out our website to see the slides and the recording video. Thank you very much. Goodbye, everyone.
Bye. Thank you.
Thank you, Terry. Appreciate it.
Yep.